The Cancer Assist Show, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Help when you really need it.
Well, welcome to the Cancer Assist Show. I'm Dr. Bill Evans, and I'm welcoming to our podcast today Dr. Elaine McWhirter. And Dr. McWhirter is an Associate Professor in the Department of Oncology at McMaster University and works at the Juravinski Hospital and Cancer Center. Welcome, Elaine. Good to see you.
Nice to be here.
So it's a lovely day in June, and the sun is out, and after COVID, people have been feeling cooped up and wanting to get out onto the beach or go to their cottage or just enjoy the sun's rays. And a good time to talk about safe sun practices, because exposing yourself to UV radiation can do a lot of damage to your skin, and the worst thing it can do, I guess, is get a cancer. And there are a number of different types of cancers that we're going to talk about, and we want to spend most of the time on melanoma, but we'll touch on some others too. But let's talk about the safe sun practices first, and there are a number of things you should do. And what's your best advice now, Dr. McWhirter?
I completely agree with you. Today is a good day to talk about sun safety, but I would argue any day is a good day to talk about sun safety. It's one of the myths that when it's overcast or dull out, not to worry so much about your sunscreen, but actually the UV rays get through, and it is still important to wear sunscreen on days like that.
That's a very good point, and I guess we tend to think simplistically that when the sun is visible to us, we should protect ourselves, but it's any time.
It is really. In particular from April to October, it's the high UV index days in this part of the world, so then when you're out and it's cooler, sunny day, that's often when we start to see burns. There are people who come into clinic in the spring. You don't think about it. You want to get in the garden. You're wearing a jacket, but for all intents and purposes, that UV index is heading into the moderate and high range, and it's there for many months. And we don't want people to be sun scared. We want you to be sun safe, but just be practical. You're looking at a sunscreen with an SPF in the range of 50. I think the key thing is find a product you like. You like the texture, you like the scent, and you're going to use it. That's the most important thing. You also need to reapply it. It really only lasts 2 to 3 hours. Mm-hmm. Another option, though, to cover up some of the sun-exposed areas would be investing in some UV protective clothing. And that's based on the weave of fabric. And look, you can get that in hats and shirts and t-shirts, pants. It's really helpful, and then you can look at making sure you have, for example, your hands covered or your feet in sandals. Don't forget those, and your face. You also want to be wearing a wide brim hat. I'm glad
people like me.
Yes, I'd be happy to see you at least in a ball cap, but you missed the all-important ears.
Yeah.
So look at getting a wide brim hat, something that's got an SPF fabric built in as well, ideally for that.
Now, SPF, for those who may not recognize that, is sun protection factor, right?
That's right.
And you said 50, right? Not 15, but the FDA says 15 and above, but you're recommending much higher levels, right?
Yes. Some data in the past few years has suggested that 50 is better than a 30. It's not a linear scale, so there's some truth to that. So if you look at an SPF 15, it blocks about 93% of the UV rays. And then an SPF 30 would be about 97, and SPF 50, 98. So it's not that 50 is double a 25, for example, but we do know that the coverage is better as you go up.
Right.
Be cautious in the water, swimming or heavy perspiration with activity. You might get a little bit less duration, and instead of that 2 to 3 hour range, you're maybe looking at 60 to 90 minutes.
So much shorter.
Yeah.
And on the sunscreen labels, the FDA has something, and I presume it applies in Canada, so broad spectrum. Is that something people should look for when they're looking at products for sunscreens?
Yes, it is. I think most of the products now really are, but you want broad spectrum is telling you it's UVA and UVB. And I would say it's pretty standard now, but if you happen to have some old sunscreen around, it may not be. And the truth is it's probably also expired. They don't last forever, especially if they've been sitting out in the sun.
Now, are some people more vulnerable to the UV radiation?
Yes, there are people who are clearly more vulnerable, and it's based on skin color. And certainly if you are Caucasian and have light hair or red hair, light eyes, you're at a greater risk of burning. And we know that blistering burns, certainly as a child or a young adult, are a significant risk factor for melanoma.
Now, if I were of another ethnicity and I was brown skin or black skin, am I more protected or not because I have that additional melanin in my skin?
Yeah, I mean, it is a good point. You certainly have some natural protection from burning, which is the big issue with skin cancers. But there is still a recommendation with other skin tones, darker skin tones, to wear sunscreen for protection. And an important area for our patients who have black skin, in terms of surveillance, they're really wanting to be watching things like the palms of the hands and the soles of the feet. Those are a lot more common, and those are obviously far less pigmented and a higher area of risk.
Oh, I didn't know that. Another thing I didn't really know much about, except in preparing for this podcast, I read up about sunglasses and the importance of choosing your sunglasses wisely too. And it doesn't have as much to do with skin cancer as what we're really focusing on, but nonetheless, since we're talking about UV radiation, the importance of getting sunglasses that have UV protection.
Yes, I agree. You should look for that little label that's on the sunglasses to make sure, again, that they have UV protection. Some of the data for the ocular melanomas and sun isn't as strong, but we definitely know it's a risk factor, and then it's also a risk factor for cataracts and other, significant eye issues. So many reasons to wear sunglasses.
And it would be easy to think that if it's just a dark sunglass that I'm protecting my eyes, right? But dark tinted sunglasses that aren't specifically with UV protection aren't saving you from the UV, so you can have
correct.
those problems. So make sure you're looking for the right kind of sunglasses. Maybe that's why they sell those cheap sunglasses on beaches or something. You can get them for a few bucks and they have no UV protection or something. I don't know.
Yeah.
But that was an interesting learning from just preparing. So we said we're going to talk about different skin cancers and.
So I think there's a few other things to cover.
Okay.
I would like to cover in terms
I'm
of.
sorry, did I rush on?
We talked about one of the myths being cloudy days or not so sunny.
Yes.
I think another important, and we focused on that April to October, but it is important to still wear sunscreen in the winter.
Okay.
Sun exposed for your face, you have to remember that you get reflection from light surfaces like snow. And so there's, even though the overhead UV index shining down is low, you get reflection off of the snow. And particularly if you are an outdoor sports person and skiing, the skiers are getting sunburned, not windburned, because then you add in the altitude plus the reflection of the snow. So very important to still remember your sunscreen in the winter.
And when you're boating in the summer?
And boating in the summer, and brings me to another excellent point. Water is a great surface for reflection, and so shade is better than nothing if that's your only option, but you have to remember the reflective surfaces such as water or light colors like white concrete or a white sand beach. So even if you are in the shade, if you're getting that reflection up to where you're sitting, it's still possible to get burned. So can't avoid the sunscreen.
Gee, you're making me want to stay indoors.
Not the point
Bring
at
a
all.
big umbrella.
Get a big umbrella, and if there's activities that you like to do for a period, if you're a swimmer or a golfer or any kind of outdoor activities in the summer, you can try and do things a bit earlier in the morning or later in the day.
Yeah, because that period of time from 10 to 2 or something is
10 to
perhaps
4.
10 to 4.
It's a big chunk of the day, and we know people want to get outside. Our summers are short. It's important to get outside, but just be sun safe.
All right, there's the message. Have we covered all the things we should cover?
Okay, I think we're good.
Good. All right, so then we're going to move on to different types of skin cancer, and skin cancer isn't one entity, so there are different types, and maybe you could just briefly outline what they are.
Yeah, so there are different types of skin cancer. So we've talked a bit about melanoma, and that is the most serious skin cancer. That's the type of skin cancer that
Not
people
the most common.
Not the most common, no. It is the deadliest form of skin cancer. We don't even have statistics on the most common types of skin cancer, which, to be clear, are the most common types of cancer, period, globally. Yeah. And then you're looking at basal cell carcinomas and squamous cell carcinomas. And it is much, much less likely to have those cancers spread or patients die from them. But unfortunately, a very small proportion of patients can die from those type of skin cancers. That would typically be more of a setting of something that you've thought maybe it would go away, and it does keep getting bigger. And so, always important if you have something on your skin that's new or changing, and we can talk a bit about that, to get it assessed by your doctor.
And are all the skin cancers all induced by UV radiation? Is that the thing?
Yes, strong connection for all of those types of cancers, yes.
So that safe sun segment is really important for all the types of cancers.
Yes, including the most common, which, again, vast majority will be cured just by getting them taken out.
Yeah. And actually, there's a variety of ways of dealing with them. It's the basal cells and the squames. I guess you can go and see your family doctor. Might cut it out or freeze it or I don't know. There are various things. Curette it.
And again, depending on where they are and the size of them, patients can be referred to dermatologists, and in some cases, radiation can be used as well. Again, depending on locations that are a bit more sensitive in terms of doing surgery, like maybe the ears or the nose or the face.
And sometimes they can be quite large if people have truly neglected them, and the surgery can be quite mutilating, and they do occasionally metastasize. And I guess that's one area where there's been some change in management, because frankly we didn't have very useful systemic therapies for metastatic squamous cell cancers of, say, the lip or something, as I've seen in my practice in the past, but there's some new treatments in the immunotherapy area, I think.
Yes, there is. I mean, melanoma is the poster child, really, for immunotherapy. Immunotherapy was developed in melanoma because it is a cancer that has, traditionally never been responsive to chemotherapy or numerous types of medications that have been tried. And what's really exciting is the, amazing results that we're seeing with immunotherapy in melanoma have been translating into these other skin cancers, including the basal cell cancers and the squamous cell cancers. So in patients, like you mentioned, who maybe have very large cancers where it would really result in very significant surgery and morbidity, again, parts of the face, those can be too large for surgery, they can be too large for radiation, and now we do have options in terms of immunotherapy for those as well.
We'll talk a little bit more about the mechanisms of immunotherapy when we talk about melanoma, but it is fascinating how from melanoma, immunotherapy is sort of spread out to virtually every kind of cancer we manage today.
Absolutely.
So it's a fascinating story. So speaking about melanoma, maybe just the basics. How would someone be concerned, or when should someone be concerned about a pigmented lesion on their body?
That's a great question. Love to talk about this because it's certainly something that patients can do themselves and then bring to the attention of their physician if they're concerned. We call it the ABCDEs of skin assessment, and A stands for asymmetry. So if you were to draw a line down the middle of that mole and one half looks different from the other, that would be abnormal. B is for border. So a normal mole usually has a nice, smooth, rounded border. If you have something that looks ragged or jagged, that would be a concerning appearing mole. C is for color. If it doesn't have a nice even color, that's typically something in a brownish range, that would be worrisome. So if it has multiple colors, which would include things like red or blue, or a mole maybe that looks like it has a bite taken out of it, it's missing a chunk of color, whereas it used to have color all through it before, that would also be a concerning appearance to see, or color. D is diameter, and we're talking something that's about the size of a pencil eraser. Something, a mole that's larger than 6 millimeters is one that you should keep an eye on. And E is for evolution or change over time. So it's getting bigger, it's getting the ragged borders, or elevation. So a mole that maybe you've had that was flat and now it's raising up should also be brought to the attention of your physician. One mole that you should always have assessed is a mole that starts to bleed. And certainly some patients think maybe they have a blood blister, but if you have something bleeding on your arm that hasn't had trauma, like the thumb in the car door sort of thing, you really want to get a bleeding lesion assessed urgently.
So another reason to know your ABCs in the D and E as well. So that's an excellent way of remembering about the factor or the various changes that can happen to a mole or a pigmented lesion that should bring you to your physician. So you go and see your family doctor, presumably, and what happens next?
So again, depending on the size of it and where it is and their comfort level, they may do a biopsy for you then and there. And if it doesn't seem appropriate to them for biopsy, they could refer a patient to a dermatologist to arrange for biopsy.
Because a biopsy is the beginning of a diagnosis, isn't it? You've got to have a look down a microscope to make sure that it's malignant or not malignant. That's the only way to deal with it. Is there an issue about incisional biopsies versus excisional, that is taking it all out versus cutting into it?
So, one of the ideally the best is something called a punch biopsy, because you want to, if you can, incorporate the whole mole, but also establish its depth. So one of the concerns, if you just, quote, shave it off the top to get a piece of it, is there could be some still in there, then you've missed the opportunity to accurately establish the depth. And the depth is part of what drives the decision of what's the surgical margin. So how big of a circle or an ellipse does the surgeon make to fully make sure that they cut this out?
And I gather in the past, when surgeons cut out melanomas, they wanted to make really sure that they were getting it all. So they had 5 centimeters around. I can't even imagine how big that would be and disfiguring that would be on many parts of the body. Times have changed, and through a series of clinical trials, emphasizing the importance of clinical trials, we've learned that it doesn't make a difference to do a big one versus a smaller one. So where are we at now in terms of the amount of excision that's necessary for one of these melanomas?
Yeah, you're right. Fortunately, those sort of 5 centimeters are not a standard anymore. Typically, it's in the range of 1 to 2 centimeters. Again, depending on the depth of that biopsy. There's a clinical trial on right now for melanomas that would be of intermediate depth in sort of a 1 to 4 millimeter range as to whether 1 centimeter might be sufficient. We know that for deeper melanomas over 4 millimeters, that's still looking at a 2 centimeter type of incision. And one of the reasons I think people wonder, why is this so big, when they know what the spot on their skin looked like? And melanoma grows in 2 ways. It grows radially, or it grows across the surface, but then it grows deep. And so really you want to make sure that you catch any of the cells that are related to the melanoma in the hopes that it doesn't come back in the years down the road.
Now, like many cancers, these tumor cells can spread, and in the past the concern was they'd spread to lymph nodes, and so surgeons took out the lymph nodes in the hopes that that would get all the cancer. It's the same sort of analogy with breast cancer. In the past, we did large surgeries and we dissected out all the nodes under the armpit, and that too is changing with new technology. I think part of the challenge too with melanoma, if you have a melanoma on your back, where would the cancer cells go? What's the lymphatic pathway? Does it go to your armpit? Does it go to your groin? So now with so-called sentinel lymph node biopsies, you can at least find out where the first cells would probably go to. And maybe just explain to the audience what a sentinel lymph node biopsy would be.
Yeah, it's very similar to what you said. It is, so it's a combination of a dye and a radioactive substance that they can pick up in the OR. The surgeon can detect, really looking for the first place that part of the skin on that part of the body drains to. In the arm, it's going to go to the underarm on the same arm, but we have multiple nodes. So this is really trying to assess what's the first node. and taking that out at surgery, and it has a very careful assessment protocol from the pathologist to look for even any microscopic, very tiny evidence of melanoma. Again, that tells us a bit about the staging of the melanoma and the risk of it coming back. Oddly enough, you mentioned the back, and that can be a trickier area because the sentinel lymph node could map to the right underarm and the left groin. And both of those areas would be assessed by the surgeon, and that would be sent off for pathology. One really big change for surgery, probably right about 5 years ago now, is prior to that, if a patient had a positive sentinel node, they would go for what's called a completion lymph node dissection, so taking out a large number of lymph nodes in that same area, whether it's under the arm or in the groin. And a large trial was published called the MSLT2 trial that randomized patients to having indeed that procedure, their sentinel node, if it was positive at a later date, going and having the completion lymph node dissection, with the other group of patients being randomized to a very close surveillance protocol where we do ultrasounds of the area where the sentinel node was every 4 months for a few years. And it was found that we could pick up recurrences with the ultrasounds, then do the surgery at that time with no detriment to patients' survival from their melanoma. So, I mean, that was really, I don't think I've ever seen a paper published that's led to a clinical translation in practice so quickly. And the other big finding from that study was there was a huge decrease, of course, in lymphedema because so many fewer people were having the completion lymph node dissections. And as you know from when you're a clinician, there is still no cure for lymphedema. And that's a swelling in the affected arm or leg. Can be managed, compression garments, lymphedema massage, but it has to be controlled really for life, and that has obviously a significant impact on quality of life.
You mentioned the quick uptake of this change in surgical practice, but another quick uptake has been the immunotherapy approach for metastatic melanoma, and that's a really exciting area, and we're going to talk about that after a brief break.
We'd like to take a moment to thank our generous supporters, the Hutton Family Fund and Banco Creative Studio, who make the Cancer Assist show possible. The COVID-19 pandemic has not stopped cancer. Instead, it has added to the isolation and challenges already faced by cancer patients and their families. The Cancer Assistance Program remains committed to providing free, essential support to cancer patients in our community, whether it be transportation and equipment loans, personal care and comfort items, to parking and practical education. With no sustainable government funding, we need your help so we can continue to be there for those who depend on CAP to stay safely at home. Individual and corporate support of signature events, third-party fundraising, and financial gifts are greatly needed. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
We're back with Dr. Elaine McWhirter talking about melanoma and really the dramatic change in treatment for individuals who have metastatic melanoma. So metastatic meaning spread to other parts of the body. And through my career, most of my career, I only had access to a drug we call DTIC, which some people have referred to as a toxic placebo. It did have a very small response rate, and I guess I can say I saw an occasional patient with some tiny benefit, but boy, it was a tough drug to take and didn't really help the quality of life of the individuals we were trying to help. But boy, that's changed dramatically. And as you were saying before the break, the advent of understanding about immunotherapy for melanoma has led to really a sea change of approach to a whole vast number of malignancies. And I don't know, maybe you'd like to talk a little bit about how that came about or how it applies to melanoma.
Yeah, immunotherapy has become a new pillar, really, of cancer treatment. You think that of the three pillars that we had, surgery, radiation therapy, and chemotherapy, and immunotherapy is really a category unto itself. It is not chemotherapy. If you think about what the immune system's usually doing, it's out there, it's looking for bacteria and viruses, and if it encounters something, it ramps up. attacks the bacteria or virus, treats the infection, and then it winds itself back down. So what we're trying to do with immunotherapy is overstimulate, excite, boost the immune system so it is so active that it's actually recognizing cancer cells as the aliens and attacking them. And in the case of melanoma, certainly it's been incredibly effective. It's been known for decades that melanoma is a very, what we would say, immune-mediated cancer, and there had been numerous vaccine studies that were all close. They had the right idea, but they just didn't work. It's been incredibly rewarding to treat patients with melanoma over the years and see that transition from drugs like DTIC, maybe a response rate of 7%, and did not improve survival and was not helpful for quality of life. To see that transition from chemotherapy to immunotherapy in melanoma has been absolutely incredible.
And this is a class of drugs we call checkpoint inhibitors. And when you were talking about the immune system ramping up to fight a virus or a bacteria, it also has to ramp down. There's got to be a regulator. And so when tumors express some foreign proteins, which they will do, the immune system ramps up, but then it gets shut down as well. Otherwise, it might overwhelm and perhaps attack normal parts of your body. So the tumors partly survive, I guess, because they figured out how to turn off the immune system. They're smart little fellas. And we've now figured out how to ramp it back up again by blocking that inhibitor, that checkpoint inhibitor. So it's a fascinating understanding of mechanisms. It's very dynamic. And so we have these drugs that work through the immune system, and have nice names like pembrolizumab and ipilimumab, and they're real tongue twisters. Don't want to say them too quickly, too often. And we also have an understanding of the mutations that occur in these malignancies. So some of those, there's a lot of mutations in melanoma, right? But some of them are what we call passenger mutations. We don't think they mean much, but then there are some that are actually driving the growth of the tumor. And again, we've figured out how to block those. And maybe just talk a bit about those, because they're important. Those mutations and the targeted agents we now have for them are part of the systemic therapy that we can use to treat melanoma, right?
They are. In melanoma in particular, it's something called a BRAF mutation. And we think of BRAF as a growth pathway that's present in cells. But the problem when you have this mutated form of the protein, it's like the switch is stuck in the on position. And so usually this would tell cells to grow, and then they would stop growing. But if the switch is in the on position, it is unregulated, ongoing cell growth. And these drugs, I mean, the work of pharmaceuticals behind drug development, a very elegant design of a drug that can bind on specifically to the abnormal form of the protein and really flip the switch into the off position. As we know, in patients that don't have a BRAF mutation, these drugs don't work, and about 40 to 50% of patients with melanoma would have a mutation in this particular growth pathway. And again, we are seeing really incredible results in terms of treatment for our patients with BRAF mutations. I mean, they still also respond to immunotherapy, but it is another tool in the toolbox in terms of treatment.
So that creates a bit of a dilemma, does it not, in the clinic? You've got, on the one hand, these targeted agents that work if they have a mutation, and then you also have these immunotherapy drugs, and how do you decide which to do first?
Yeah, there's a number of factors that go into that. There's certainly studies that have looked at retrospectively, but looked at who are the patients that seem to have a long-term response to the BRAF inhibitor type of drugs, because in fact most people will respond. It's a question of how long. And we actually combine the BRAF inhibitors with a second drug. Again, a growth pathway has a number of steps. And it was found if you block not only that first step of the BRAF protein, but a second one called MEK, that the duration of the response was longer. And so the median numbers are about maybe 12 to 13 months in terms of the average, how long the average patient would respond. but we know some patients might only have a response for a few months, and some patients will be responding for years. And there are some factors in terms of how much tumor a patient has, how well they are, some blood tests that we can do that would suggest that might be a patient who would have a long-term response. So there are patient features, and always, again, patient preference. The BRAF inhibitor combinations are pills. Immunotherapy is intravenous. So, these are conversations that we have with our patients, but there's certainly some features where we would suggest that we think for a longer term response to treatment that immunotherapy would be preferable.
So let's drill down just on how long or what proportion of patients have a long response, and are any patient cured by immunotherapy?
It's there's hesitation in this field, as you can imagine, to use the C word for cure, but the response to immunotherapy and the longer term data, which we keep getting updates, which has really been very helpful, has been incredible. So we really, there's two main classes of immunotherapies in melanoma. I don't want to get too technical for a group here. The first group of drugs was the ipilimumab, which are CTLA4 inhibitors, and the second group of drugs are the PD-L1 inhibitors. And, logical question, if one drug works well and the other drug works well, what happens if you can combine them? And so ASCO is the big international annual cancer conference that happens at the end of May. Updated data now at 7.5 years is showing that just under 50% of patients who received the combination of these drugs are still alive and well at 7.5 years after starting treatment.
With no evidence of disease?
With no evidence of recurrence. It's an interesting thing with the immunotherapies. Sometimes where we knew there had been tumors, for example, in the lung or in the liver, they shrunk down, but sometimes they don't entirely go away. Some studies that have done biopsies of these sort of leftovers have shown that it's all immune cells, inflammatory cells with no active tumor. So as we follow these patients over time, these sort of leftover spots that we knew at one point were tumors, if they're not growing and they're not multiplying, we don't worry about them. It's looking close to cure, I guess, when you're talking about 7.5 years out.
I would say so. You're being very cautious. We used to say if you've survived 5 years disease-free, you were probably cured. And we know that isn't always the case, but it's extremely encouraging that there are these individuals who are living a long time with apparent disappearance of metastatic disease. As a consequence of the effectiveness in advanced disease like that, then I gather immunotherapy is being applied at earlier stages of disease, either post-operative as a so-called adjuvant therapy, an additional therapy post-operatively, or even before the surgery.
Mm-hmm. It's been another huge move forward for our patients with melanoma. The older treatments was maybe even when you were in the clinic was interferon, and it was an incredibly toxic treatment. Yes. It was a 1-year program and unfortunately not very effective, but it was all we had. And so, in cancer in general, when you find treatments that are so effective in patients with metastatic or stage 4 disease, it's the next logical question is, what if we introduce these drugs after surgery? And, and that purpose is especially for patients who had larger melanomas or melanomas that spread to the lymph nodes. Are there any theoretical leftover melanoma cells that we can use the immunotherapy to take care of those, so in the years down the road there's less likely a chance of this cancer coming back? And indeed, that's what we've found with immunotherapy, and as well with targeted therapy. So for our patients with melanoma, we have options to offer them to try and prevent the risk of their cancer coming back.
So are you using targeted therapy as adjuvant therapy and also immunotherapy as
Immunotherapy.
adjuvant therapy?
Yeah, one or the other, but
One or the
yeah,
other.
they're both options.
Are they ever used in combination, like immunotherapy plus targeted therapy?
Yeah, not in this setting, not in the
No.
post-operative setting. It certainly has been studied in the in the setting of metastatic melanoma, and it's a case of, despite having two very good treatments, that three, for the most part, has not looked to be a lot better than one. So sorry, three, the two BRAF combination. So
Right.
targeted therapy plus immunotherapy has not, the results haven't been as good as we would have liked. You know, certainly we had those studies at the Cancer Center. We've had some patients who've done very well on the trials. But that has not hit prime time. I think we need to look a little bit closer at design. Of course, you know, we've made the story a little bit simplistic. There are a number of what we call checkpoints of the immune system that we can try and target. And some recent studies have looked at another target, something called LAG3. In combination with the PD-1 inhibitor, and that also is looking to be a very effective target. It's pretty early days, just been approved by the US FDA. Doesn't have approval here yet, but we continue to study. We continue to look for treatments that are going to give our patients excellent quality of life and long lives.
Well, this is the importance of doing clinical trials and advancing knowledge progressively. One area that I'd be interested to hear about what its status is just vaccines for melanoma, because herpes simplex virus attenuated has been used as a vaccine. Is that going anywhere? Is there any promise in it or not?
Yeah, I mean, there's one in particular, the TVEC, that has shown good results. It is used in the States. There's some logistical aspects in terms of, you know, where you inject this, and really the more effective use seems to be perhaps in combination with immunotherapy, and that's certainly been under investigation. So that's not really prime time here yet, certainly as a single agent, but that could be something down the road in combination with immunotherapy.
Well, it just goes to show that there are various ways to stimulate the immune system, and a lot of activity in an area. I remember when we tried to stimulate the immune system back in the 70s, it was with interpleural BCG and things like that, so it seemed very primitive in comparison to the kind of sophisticated interventions that are informed by basic science today. So there's been tremendous advances in the management of melanoma. I think it's really one of the biggest success stories in oncology, right? And what do you see in the future? How's the picture going to unfold? Because you're I guess I'm not supposed to say cure, but my goodness, people living disease-free for 7.5 years sounds pretty good to very close to a cure, but you're certainly having very long survivals.
Very long survivals. Again, it really is speaks to clinical trials, looking at different combinations. You know, we're going to see more improvements in survival with our adjuvant therapies, and perhaps, again, some combinations or other drugs might move into the post-operative setting. And as you touched on, looking at using these treatments before surgery is certainly, you know, data that's come out so far looks very promising. And I do think that will be something that we see more of down the road, is actually patients receiving either targeted therapy or immunotherapy before their surgery. It's even having some impacts on whether or not, you know, patients need more lymph nodes out as well. So very exciting.
Lots of changes. So I guess I'll bring you back in about 2 or 3 years, and you can update us again and all the new and exciting things. What messages would you like to leave with our listeners about Safe Sun and about melanoma today?
I think messages, especially for patients or their families who are dealing with melanoma, is certainly there's a lot of hope and optimism for treatments that can help our patients, and clinical trials, and we're, you know, deeply indebted to our patients who agree to participate on clinical trials to try and move treatments forward for everybody. Again, with a disease that is preventable, and you know, we can't go back in time and erase the sun exposure of our youth. But moving forward, very important to stay sun safe, and certainly for those of you with children, start them early and prevent the burns. And I think if we can really, as a country, get that public health message out in terms of the importance in sun safety, instead of this being a cancer that worldwide has an ongoing increase in incidence, we'll be able to try and turn that down and eventually have fewer cases.
Well, hopefully this podcast will do a little bit towards that and informing people
wonderful.
about the safe sun practices we talked about at the first of the podcast. And it's certainly great to hear the hopeful messages about the advances in the treatment of advanced melanoma. It's really one of the great success stories, and it's continuing to evolve, and I suspect over time the results will simply get better and better. Dr. McWhirter, really want to thank you for sharing your knowledge with us today on this podcast. I think the listeners will find it very interesting to listen to, and hopefully they action what you said about safe sun practices.
I hope so.
Okay.
Well, thank you for having me.
Okay.
This has been the Cancer Assist Show, brought to you by the Cancer Assistance Program. Thanks for listening.